Well, welcome everybody, and to this seminar of the Center for AIDS Research's Bioethics and Human Rights Scientific Working Group, which we're also, to some degree, joining in with the LGBT Curriculum Working Group that is underway here at the school that some folks in the room are part of. That's a parallel process in some ways where we're trying to develop more of a curriculum here and have a high-level speaker series and people who are really working in this area join us. And so we're delighted to have two folks, the distinguished James McIntyre, who really is a leader in the field, who I'll introduce briefly, and the also distinguished emerging newly appointed assistant professor in health policy and management, Danielle German, who's the PI of the Be Sure studies here in Baltimore, working with MSM in our city, and drug users and other key affected populations. So we're going to be talking today about the whole issue of research around men who have sex with men. And we're going to start off with James McIntyre. Now, I have known James for many years, and from when he and colleagues set up the perinatal HIV research unit at what was then, I guess it still is maybe, Africa's largest hospital, Chris Hani Baragwanath Hospital in the township of Soweto, really focused at that time on the huge issue of perinatal transmission, but also on antiviral access treatment. And he and his group have done really groundbreaking work in that area. And then in the last several years have really done more and more with men who have sex with men. James is now the executive director of ANOVA Health, which has the first two PEPFAR-funded really comprehensive treatment programs for men who have sex with men in South Africa, one in Cape Town, one in Johannesburg, and you're opening two more, is that right, to come. And these really are amazing places. I've had the good fortune now to have visited both, and really doing impressive work in what we know is a very challenging environment for sexual minorities. And James is a physician. He's a visiting professor at Columbia, in addition to having an appointment now at University of Cape Town. He has all those interesting British letters after his name, the MBChB and the FRCOG, because he actually is an obstetrician gynecologist by training, and he's a fellow of the Royal College of Obstetrics and Gynecology, an HVTN investigator in the past, an HPTN investigator, an impact investigator, a UNITAID investigator, probably in the human rights arena, most importantly, an awardee of the Nelson Mandela Prize for Human Rights for having taken on, as many of you will remember, the truly damaging health policies of the Mbeki administration, and standing up to them with science and evidence for prevention of mother-to-child transmission, which makes him a hero, which he is really, actually. All right, James.
Thanks, Chris. If I can work out which of these. I'm not really sure what I can come here and tell the people who wrote the book on this, actually, with Chris and Steph in the room. But I thought that I would focus mainly on some of the issues around engagement and hope that Danielle would cover some of the ethical issues that follow. And tell you just a little bit about some of the things that we've had to think about in setting up the programs that Chris has spoken about in his introduction, and some of the initial research that has happened in the South African setting. So I'm not going to talk much about statistics, but right now it seems to be that there's a major new focus on men who have sex with men. And there's, for every person who is blogging away about MSM, there's somebody blogging about how MSM is not an identity and how they don't like to be called MSM. And fascinatingly, I'm finding in some of our settings that MSM is becoming an identity in an African setting, that guys are saying themselves, I'm MSM, rather than identifying as gay. But clearly it includes gay and non-gay identified men, and those who engage in situational sex in prisons or other things. And so why this renewed focus? Why this new way of thinking that MSM is actually a community or a population that is important? Well, I think that it is of public health importance even in generalized epidemics, and nobody's shown that better than Steph and Chris. They're marginalized, they're often invisible, but there may be significant numbers of these groupings of men. And in African settings, most men who have sex with men also have sex with women. And so it is something that is impacting on treatment programs, impacting on prevention programs all over Africa. And we know very clearly that prejudice prevents MSM from accessing health services and also from accessing research opportunities. They are, however, at high risk of transmission and acquisition, and that's true in America as it is in other countries. And you know well that gay and bisexual men account for 2/3 of new infections in the US, with young African American men accounting for more than any other group. They have an increased risk compared to the general population, even in Africa. And if in our first study in Soweto, the Soweto Men study, we had an HIV prevalence on average of 20%, with high rates of unprotected sex and high rates of men who also had sex with women in that trial. And that's backed up by another South African study a couple of years back that showed an HIV prevalence in MSM of 43%. So really significant numbers, and we're not even sure on a country level what this translates to. I think there's also a renewed focus because MSM are becoming at an international level a priority for targeted health interventions. And targeted health interventions need targeted research if we know how we're going to do it. That's true in the US National AIDS Plan, it's true in the PEPFAR guidance for MSM, and it's true in the South African National Strategic Plan. And Dick Chason's trying to put his glasses on to see who it is. Princess Stephanie, the health minister talking to one of my staff, and Michael Ballack, a European footballer, Dick, in case you didn't know that. So everybody is suddenly wanting to be in on these clinics. But we know that MSM also have multiple vulnerabilities that impact on both research and on their care. There's a whole central inequality around sexual orientation. There's discrimination. There's a lack of access to services. There's victimization for people who do make it through to services. And there's a background of religious and cultural intolerance in many, if not most, communities. And once we talk about MSM in Africa, we come up often against the un-Africanism of homosexuality. It's not African. We come up against the ongoing criminalization of MSM. We come up against stigma and discrimination throughout communities. And African MSM currently are facing unprecedented prejudice and discrimination, which culminates in human rights abuses. And so engaging MSM in Africa, whether it's engaging them in care, whether it's engaging them in prevention programs for HIV, whether it's engaging them in the research that can inform those programs, is difficult. Often they're not self-identified as gay. Again, in the first Soweto Men study, 83% self-identified as gay, 12% as bisexual, and 1% as straight. But that is quite different in many others. And when you balance that in other countries, South Africa has the most liberal constitution in the world in this regard. But across Africa, that's not true. Homosexuality is outlawed in 38 African countries. In 4, it can carry a death penalty. In 13, it's either legal or there are no laws, generally no laws. And so providing MSM-focused services or enrolling MSM into studies in these countries becomes a major challenge. Does it come with a burden of reporting for the researcher? Can the researcher provide care without putting participants at risk? Does identification of being a study participant put somebody at risk of being thrown into prison? And I think we've seen in the last couple of years, we've seen this movement of anti-homosexual fervor, if you like, really come across a number of countries. And 2010 is the kind of sparking point, I think, for all of that. These are scenes from Mombasa in Kenya, which, after rioting, that was caused by rumors of gay marriage, of a gay marriage happening in the area. But what's even more concerning is that these gay men were dragged from the Kemri Research Institute building where there had been studies going on, and the mob at that point was threatening death by fire. In Malawi, 2010 again, a couple who had become engaged and who were then arrested, subsequently pardoned, but causing a major upturn in the community. And then in Uganda, both in 2010 and still ongoing, the infamous bill that's threatening the death penalty for being gay in Uganda for repeated offences. And South Africa has not been immune to that. South Africa, despite a constitution that enshrines gay rights and gay marriage, really has a traditional culture that I suspect if you were to put this to the vote in the South African Parliament today, it would all be gone, quite honestly. And I think this quote that South Africa remains a homophobic and heterosexual society where across cultures homosexuality is pathologized, and where the notion that homosexuality is not African continues to play itself out even in that setting. These are quotes from focus group participants in one of our studies in Cape Town. In our culture, we're not allowed to be gays. That's absolutely Satanism. Some will say it's because of the culture that's enforced. You have to have a wife. You've got to have children. Your sexual status is not counted as a thing. It's only that you're a man, so you have to behave like a man. So those are the identities that people are coming up against. And at the highest level, we've seen politicians, not only in Zimbabwe and not only in Uganda, making statements that would be pretty worrying. Here's South Africa's current president, but in 2006, before he was president, saying when he was growing up, a gay man would not have stood in front of him. He would have knocked him out. And that same-sex marriage was a disgrace to the nation and to God. You know, presidents evolve in their thinking all over the world, luckily. And we are seeing something somewhat differently now when he's saying we're faced with different challenges of reconciliation and building a nation that does not discriminate because of color or sexual orientation. Let's hope he continues evolving in that direction and not backwards. But the South African government certainly has taken that step, and that has made it a lot easier to consider how to provide services that are targeted towards MSM and are targeted and research that is targeted to informing how those services can happen. This is the current health minister. All people, regardless of race, culture, gender, HIV status, or sexual orientation, have equal rights to the provision of services. So we work within an environment not only in the US, but certainly we're lucky enough in South Africa to be in the same environment where we're seeing politicians say the right things, saying equating gay rights with human rights. They're not divisible, it's not a Western invention, and it should never be a crime. So hopefully that's the movement that will come downwards from the north and come upwards from South Africa as we start to see things change. Having said that, there are certainly challenges in working with MSM as a group, both in research and in the provision of health services. This is from Steph some years back, I think, but finding the invisible men remains one of the issues. Men are not going to come forward and self-identify as MSM if they are treated badly, or if there is a risk of any form of punishment or non-legal activities. There's also a range of sexual identity and behavior, as we've seen many reporting both male and female partners. And sexual identity does seem to matter. In MSM in Soweto, in this part of the study, if you look at the top line, those who self-identified as gay had an HIV prevalence of 48%. Those who self-identified as straight but had male partners had a HIV prevalence of 16%. And if you take that prevalence in young gay men in a Sowetan setting, that's equivalent to what we see in young women in South Africa. So generally in a Southern African setting, the peak prevalence rates in men is between 20 and 24, or above 24. In women, it's younger than that. And in these young gay men in a Soweto setting, the rates that we were seeing were equivalent to young girls of the same age. And I think they face the same risk factors. They face the same lack of empowerment and the lack of ability to determine their own course in their sexuality. This is a quote from, again, one of these studies. People are aware of gay and lesbian people, but accepting them is another story because they don't understand what you're going through. They see you as a different thing. Not they see you as different. Not they see you as unusual. They see you as a different thing, not quite a person. And that happens, unfortunately, very often in our healthcare services. The experience of discrimination based on sexual orientation at clinics and health facilities is an important deterrent to seeking medical care, to going for HIV testing, to enrolling into studies. Health facilities are viewed as places where healthcare workers threaten the right to privacy and confidentiality. They engage in gossip and in homophobic verbal discrimination. Here's another quote from Cape Town this time. They said, "Are you a man? Are you a real man? What do you want here?" And they won't get you help, and they just laugh. If that's what people are facing within health services, I think we can't expect them to be standing in line to be subjected to it, even if they do have health needs. What we found is that MSM in our communities will seek out clinics that have reputations for employing healthcare workers who respect privacy and sexuality and respect their sexuality, and will challenge sometimes those who mistreat them. And many non-gay identified MSM present masculine heterosexual identities when presenting for sexual health problems and avoid discussing their sexuality, making it very difficult to make a diagnosis and making it very difficult to care for them. Here's an example. There were 2 gay men at the clinic. One apparently had an STD, and the nurse said to them she expected that. She wasn't expecting them to have flu, but an STD because they sleep around and God was punishing them. And the nurse will ask questions like, "What was in here?" meaning in the anus. It makes us afraid of going to the clinic to get treatment, and that's why many gay men get sick. So I think that narrative of discrimination within health services and discrimination by health workers is one that extends right across Africa. And it's something that I think is central and crucial to enabling research within health facilities. The other thing I think we have to recognize is, as we talk about MSM as this all-encompassing term, diversity matters, and they're not one population. Different men have different needs, they do different things, they hear different messages, and they're engaged in differing ways. These archetypes were from one of our early prevention campaigns in Cape Town, and actually were a great hit within that community. Everybody they weren't quite pins, Dr. Chasen, but I think we might think about doing it that way. And when we think about that diversity of sexual behavior, we know that sex occurs in diverse circumstances in men with different experiences and lifestyles and risks. They may also have sex with women, may transmit the virus to female partners, or be infected from female partners. And in a generalized epidemic, such as in South Africa, it may well be that most men, even if they have sex with men, are at risk of getting HIV from women, just because of the dynamics of the epidemic in that setting. They're often married, especially where there are discriminatory laws or social stigma, and sex between adolescent males can be part of sexual experimentation and a phase in life that may not go on forever. I think that we need to consider particularly programming needs for transgender people. There are a few epidemiological studies, but those that are there show disproportionately high HIV prevalence and high incidence in these communities. The underlying correlates of HIV and STI risk and the sexual health needs of transgender people may be very distinct from those of MSM as a catch-all term. And although the basic prevention interventions may be indicated for both groups, health professionals need to avoid conflating the two groups and work towards a much more nuanced understanding of the needs that are there. So the way in which we've tried to do this is by taking the approach that MSM-focused health services, in fact, provide the intersection between behavior and medical needs. And HIV testing really is often the entry point into either side of that. So what we've done with our Health for Men services and what we're trying to roll out further is that those services can supply condoms and lube. They can provide counseling, both individual and couple. They can provide support groups, prevention with positives. In our Cape Town clinic, and that's the only one that I'm aware of in South Africa, needle exchange and IDU interventions, which have not yet happened on a broad scale. They can provide and contribute to education on sexual and psychosocial health and promote responsible sex. And what we've done, as I'll show you in some of our prevention paradigms, is taking the line that responsible sex is safer sex, but that sex is good, and that we're not trying to stop people having sex, we're trying to make it responsible along the way. On the medical side, sexual health checkups, HIV counseling, CD4 viral load, HIV care treatment and ARVs, and STIs, which we find are really important in bringing men into clinics. And vaccinations against viral STIs are something that are not common in an African setting, but which we are trying to work on as we do with sex worker targeted services. There are challenges in doing this kind of thing within the health service. We thought initially maybe it was just the health workers, and if we got better ones. I have to admit that the one in the middle is a porn star, and the one on the left-hand side is actually my PA. But anyway, they weren't really nurses, but it was one way in reaching hidden non-gay identified MSM is to have a really good float in the Pride Parade. It does put the numbers up. But stigma and discrimination abound still, and we have to get over those perceived barriers. We find that it's really difficult to design content that reaches a broad group of MSM in an African setting and disseminate that content appropriately. There are very complex taboos around sexuality. What you can discuss in a bar in Cape Town is not what you can discuss in a township in northern Limpopo. There's a great deal of recreational substance use and abuse. There are numerous mental health issues that I think when we first started providing clinical services, that the mental health issues have been much, much greater now that we've provided the service, and so we've seen that. And that, I think, also impacts on how you can enroll people into trials in these settings as well. And there are very complex relationship dynamics. So the two centres that Chris referred to, the Ivan Tom Centre for Men's Health and the Simon and Corley Centre for Men's Health, are the first two PEPFAR and South African government-funded clinics. This is the Cape Town clinic at the moment that provide accessible MSM care. I think they're probably the largest such service in a state clinic service in Africa. We aim to minimize barriers and attract MSM into that care. And we work from that to provide a great deal of training that is trying to facilitate and develop and mainstream the skills. And that is based on facility-level training that sensitizes an entire facility to MSM and other most at-risk groups. We're doing that now into 4 provinces in South Africa. Peer educator training, doctor training, and master classes with people who are working in the field. We also use the health service to provide biomedical prevention research opportunities and prevention messaging. The messaging links always to HIV-targeted and MSM-targeted health services. The outreach activities promote, however, not only HIV, but a more holistic men's health approach, so that we don't always equate MSM with HIV. And we believe that these kind of clinics can provide a safe place for research activities. Education and outreach is therefore the first way of engaging. These are recent ads from some of the gay press and the famous, thank you, Chris, for using the picture, Health for Men black condoms, which have been a great hit in South Africa. And we've started to look much more at how to communicate using technology for youth and how to properly target that diversity of MSM, recognizing that cities are not equal to townships, which are not equal to rural areas. We work a lot through ambassador programs and peer educator programs, community consultation and participation, and monitoring. And reaching young MSM in an African setting is as challenging as it is here in the US. Clearly there's a need to reach young guys in their spaces. This is the top picture is the Gay Pride Parade in Johannesburg last year, I think. We know that the highest HIV prevalence in the studies that we have so far are in guys under 25 years old. young MSM in our Cape Town research are conversely more likely to identify as gay, which might provide access to messaging that is easier. And a higher percentage of young MSM would opt to receive messaging through a cell phone than older MSM. We think that the messages then that we put out, whether they're around research projects or education, need to be context relevant. So probably shouldn't be scratching that off. What we do in a bar in Cape Town with the scratch pads is very different from the posters that go up in taverns and townships. And those in turn are very different from the ads that go into township newspapers. So we work across a spectrum of those. We also believe that there's a need to continue research on structural interventions. This is not only around individual behavior. There's very little data in an African setting yet between the interaction between MSM sexual behavior and poverty and unemployment. There are reported high rates of transactional sex in MSM studies, suggesting that similar dynamics of socioeconomic need drive that sexual behavior, just as they do in young girls in a Southern African setting. The Aquazona Project in Cape Town that we're doing with Andy Tucker from Cambridge uses structural approaches that take into account the social circumstances that can hinder that individual ability to practice safe sex. And it's run through ambassadors here sheltering under the umbrellas, who are out in township areas, which raises its own difficulties. We've had these guys handing out pamphlets on trains in Cape Town, being beaten up, being accosted, being sexually harassed. It focuses on structural interventions such as promoting overall human rights and where gay identity fits within that. And these are all posters that appear in the shebeens in the Cape Townships. It focuses on HIV risk reduction and the methods such as condom and lube, and on STI risk reduction. And it also talks about transactional sex and talks about sex work. And the ethics of how you deal with this becomes interesting. The poster with the banknote, when we first checked it out with focus groups with some of our ambassadors, they said, you can't put that up, because people will think they can't buy drinks for us. And those are the people who are working, trying to put over these messages. So it takes a lot of in-depth thinking. Also, when you put this out, I think as researchers, we tend to think that the person who's being paid for sex is the young MSM in the Cape community. In fact, it's the opposite way around often. They are paying older, drunk, straight guys to have sex with them because they're perceived as having disposable income. They're perceived as being out for a party. And so it turns around many of the perceptions that we have from working in other areas. We then also work with a slightly more nuanced, different approach within community newspapers, which also is aimed at bringing these men into contact with the health services. And this is a billboard, and it says something about South Africa as a country. That this billboard sits, as you can see from the bottom picture, in the largest taxi rank in Khayelitsha Township in Cape Town, and is very open. I think for people who the message gets through. Let's say it's not completely in your face, but it's open enough for people to understand. We've also looked at how to harness new technology to reach and engage MSM. We work with a Mobi site. Cell phones, there are more cell phone SIM cards than people in South Africa. Cell phones are now completely ubiquitous. Most people only have internet access through their cell phones, not through computers. So this for us is really the best way to go. This is a Mobi program which has information, interactive polls. You can ask questions, get replies. It's accessible at low cost from even quite basic cell phones. And we also do work within internet dating sites. This is a South African equivalent one that has a racial mix of about 2/3 white, 1/3 black, but quite a young group of guys. We've used those sites to start doing some online surveys. This is one from last year. This is people, I remember, they are answering online, so this is not completely generalizable, but those who found sex partners online in the previous 6 months, and if you look at the total, it's about 2/3 have found a sex partner online, even in a South African setting, which sometimes we think doesn't happen. And it's pretty similar whether they were self-reported HIV positive or negative. And when we asked about condom use, if you just look at the total bars, you can see that the top one is condom use and receptive anal sex in the last 6 months, and about a third say every time, and it goes down from there. And if you look at the HIV negative, it's slightly higher than that, a little bit lower in those who are self-reported positive, and condom use in the bottom one in insertive anal sex looking pretty similar. I think that the online research opens up opportunities to get information that's not easy to get face-to-face with people, but it does clearly carry some risk. So what we're trying to do in these programs is understand South African MSM and the risks, research the drivers of the epidemic. What are the behavioral factors? What are the mental health factors, which increasingly we see as important? What is the role of recreational drug use? We know that alcohol drives the African epidemic to a great extent in the heterosexual population. In a gay population, is it any different? What is the double stigma for HIV positive MSM, and what does that do to prevention with positive messages? And what do the poor experiences of mainstream health services do to get people into care and keep them there? I think that we need to, as we think about research needs, acknowledge the false divide between biomedical and behavioral strategies. Everything that's biomedical is also behavioral. And the implementation of successful biomedical interventions provides opportunities to refocus on behavior modifications, including strategies to reduce risk linked to alcohol, delaying sexual debut, decreasing risk from drug abuse, such as needle exchange programs, and reducing the risk from multiple partnerships. We need to acknowledge the diversity of the population as we plan research. We need to consider the diversity of behavior, the range of risk that they face, the range of factors which influence that risk. And we need to accept that traditional community involvement, as we would define it within US studies and as we would define it within NIH networks, is very difficult for this group because they don't themselves define themselves as a community. So understanding how to interact and be respectful of community input is quite challenging. We need to know who the men are. How can we be sure that we are reaching the range of MSM? How can we be sure that the messaging is appropriate for the diversity of that population? And how much do we actually need to do that? How generalizable can our findings from research be if we don't know what the community really is? And we need to know what they do. There's a lot of biomedical ARV-based research in Africa. There's very little research on sexual practice, either heterosexual or homosexual. There's a traditional reluctance to discuss sex, which affects researchers very often more than it does the clients. So training research workers appropriately becomes a huge challenge if they're going to ask questions in the right way. And there's little knowledge of the clinical conditions because there's little experience in providing MSM services. So I'd like to just have a quick ad before I close and point you to an upcoming supplement in AIDS and Behavior, which should be out in print version in April, but all 9 of those papers are available online, including one from somebody called Baral and Beira. And these, I think they're an interesting package of papers around MSM research in South Africa that raise a number of issues and provide a lot of information from several of my colleagues. And with that, I'd like to end and to say thank you very much for the invitation.
Well, thanks so much, James. And it's such important work, and it's great to see, really how quickly things have gone into provision of services. Just before I introduce Danielle German, let me just say that we are having a meet and greet for folks to talk with James and Danielle. That will be right after this session at from 5:15 to 6 in 2015. Is it W 2015? In W 2015. So please do feel free to come and nothing scary about James. So Danielle German, as I said, is an assistant professor now in health, behavior, and society. She is a graduate of our distinguished institution and is heading up the Be Sure studies, which are CDC-funded bio and behavioral surveillance for MSM and drug users and other folks at risk. So Danielle, please.
So thanks. It's actually my pleasure to be here and to share with you a little bit about what some of the work that we've done in Baltimore, and what's really interesting about following the wonderful talk that preceded is really how far away we are and really how similar we are in so many ways. So what I'm going to talk about is just some of our Baltimore context and some of the things that we've done over time and some of the things that we've learned over time in working with the MSM community here in Baltimore. And there are a number of people in the room, I'm glad to say, who are very familiar with some of the things that I'm going to be sharing. And some of the things very deliberately that I'll be sharing are things that we've shared a number of times, and that's sort of part of the story of the kind of work that we're doing here in Baltimore. And I want to say also that some of the structure of these slides is actually pulled pretty directly from an opportunity that I had about a week and a half ago in the context of a project that I'll tell you about, where we met with a group of community leaders here in Baltimore and had the chance, as part of the work that we do, to talk with them about what's going on with the Baltimore epidemic, some of the work that we're doing, and some of the work that we hope to be doing. And what I've done partly to sort of share with you how we do our work is really take a lot of that structure and bring it here. The conversation tends to I think, parallel in a lot of ways. So my entry into work with MSM here in Baltimore was very much in the context of the Be Sure study. And as Chris mentioned, it's part of CDC's National HIV Behavioral Surveillance Project, which operates in about 20 plus cities around the U.S. The idea is to work in the cities with the highest rates of HIV to understand the drivers of HIV infection among the populations at greatest risk for HIV in those locations. And so what we do is we do rotating cycles of data collection with injection drug users, with heterosexuals who are at high risk, which tend to be defined as a lower income, low SES population, and with men who have sex with men. And we do a pretty comprehensive socio-behavioral survey, and we also do HIV testing in each of those populations. As part of that, then we have done over time, we've done 3 waves of data collection with men who have sex with men here in Baltimore. And so the first round of that data collection happened in 2004, 2005. And what I'm going to do is sort of share with you the HIV story for MSM in Baltimore, because it very much shapes the context of any of our continuing work in what it is that we're trying to do. So all of our data collection, particularly, for the MSM rounds, it's a venue-based type data collection. So we're out in the community, sort of working in the places where guys tend to be. And so this just gives you a really quick picture of what we've seen in Baltimore for HIV and the patterns of HIV infection over time. And what this shows you, if you follow the bluish line that starts right here and goes upwards, you'll see that around 2003, 2004, there was really, MSM were part of the HIV story in Baltimore, but there was very much an underappreciation that HIV was a priority, and that's around when our first round of data collection took place. And the Be Sure data, as I'll show you, became a pretty strong awakening in the city for something that was very much known among the community of people that were living it. They were seeing their friends getting sick. They were seeing, that they were going to funerals rather frequently, but it wasn't very widely acknowledged among service providers, among policymakers, among people who were disseminating funds. And what we've seen, so essentially what we've seen over time is that the standard case surveillance has really caught up with some of those early indicators, so that we're actually at a point where the prevalence in our state surveillance data have started to match what we're seeing in our behavioral surveillance data. So very much a strong, sharp upswing in HIV infection among MSM, and a sort of relative drop in other populations in terms of proportions. And then also what we see in our case surveillance is a very strong and persistent racial disparity. And so from the very beginning, HIV has been very strongly concentrated among Black or African American MSM relative to men of other ethnicities, and that's been persistent all the way through. So what we've seen in our BSure data collection, and for those of you who are seeing behavioral surveillance and hearing me say BSure, the acronym stands for, it's one of the better acronyms, and I would spell it out for you if I could, and I didn't have anything to do with it, so I can claim how wonderful it is. But it just stands for Behavioral Surveillance Research, and that's BSure. So what this shows you is what the top line shows, or I guess the bottom line shows HIV prevalence the first time around, which is that we went out in 2004 and approximately 40% of the men that we saw tested HIV positive with us. And what the top bar shows is the proportion of the men who tested positive with us who did not report that they were HIV positive when we saw us, so what we refer to as unrecognized infection. And so that was 2004. At that moment, a lot of people sort of stopped short and said, wow. And quite frankly, the general perception was that we must have kind of done something wrong. This wasn't matching most of the other indicators that were going on. And it took our data collection in 2008 which showed essentially the same HIV prevalence and, certainly no better indicator of the unrecognized infection. And then we went out again last 2 years ago, and we saw a very, very similar pattern. And as I showed you, that is now absolutely showing up in other indicators. Now, what's also really important about our Baltimore context is that absolutely we have this very, very strong and prominent racial disparity in how HIV is existing among MSM. And so approximately, pretty much across the board, approximately half of the Black men that we see and that do their HIV tests with us test HIV positive, compared to under 20% approximately among the white men that we see. And we see this persistently over time. And there's a similar, it's not quite to the same degree, but a similar rate where even among a community where we see about half are HIV positive, a striking amount of those people don't know that they are HIV positive. We see also, concerning rates among white men.
Danielle, can I just ask
Yeah,
a quick,
sure.
Are these new cohorts each time you go out?
Mm-hmm.
That's what I see.
Yeah, so it's exactly. So it's serial cross-sectional studies. And so this just shows you a breakdown by age, and what it shows is that among Black men, there's in each of the age groups, we see at least approximately 40% prevalence. So there's not a lot of age variation. To the extent that there's a stronger concentration, it's in this sort of 25 to 44-year-olds, but there's not really a lot of age variation, which is different when you look among the white men. It's important to know that in our studies we tend to see many fewer white men compared to African American men, which is also reflective of what the social context is when you're doing venue-based recruitment in the way that our venues and the sort of social scene in Baltimore has kind of changed. And again, there's some sort of age story among the unrecognized infection, but not a dramatic one. So among younger people, we're certainly seeing a lot of need for infection, and then among white men, a different story again. Although the number of people that we see with unrecognized infection among white men is very small. So what this shows, we've spent a lot of time, like other people, in trying to figure out, what might be different among Black men and white men in the city that might help us to understand what's going on with the HIV epidemic. And essentially what we see, like many other people have seen, is that behaviorally there's not a lot of difference. But strikingly, where there are very dramatic differences between the white men and the black men that we see are in these social indicators. And so what we see is that among black men, much higher poverty or lower income, higher rates of unemployment, substantially higher rates of incarceration, of homelessness, lower education. And so a lot that gives us a really strong sense that is reaffirmed by the community left and right that HIV is not the strongest priority on a day-to-day basis. The day-to-day needs are very much part of the story. And this is compounded by also many indicators that stigma related to sexual orientation, compounded by stigma related to race, ethnicity, compounded by stigma related to HIV, that all of those things are absolutely part of what's going on here. So I won't dwell here, but just to say that we just have very strong indications that even given all of these the social indicators, that the patterns that we're seeing among black men are really powerful. So this sort of brings us to this interesting place in the current attempts to do work in this community, which is that in 2004 we came out with these numbers that said that should have sort of stopped us all cold and said this is an emergency, this is a crisis, and it did stop a lot of us cold. I don't want to say that it didn't, but then a couple of years later we came out and we said, well, we have a crisis and we should all stop cold and we should do something about it. And that sort of same dialogue has stayed pretty prominent among the group of people whose community this is and who have been sort of screaming to have this be noticed. And we're at a point, sort of 10 years later where we're still kind of saying that. And the challenge is that for the people whose daily life this is, they're not really believing that people are paying attention. The emergency message certainly isn't quite getting through. And what they're seeing is that we researchers kind of keep coming out and maybe doing some useful things. And there's a value. And when I present these data to community members and to community leaders, they sort of twiddle their thumbs as I'm going through it because they know this stuff. They've heard it. What they want to hear is where are the dramatically amazing things that are happening that could do something about this. And so it becomes a sort of difficult dialogue to continue to have. And so we're at this place now where certainly there's a demonstrated need for a lot more attention and a lot more work. At the same time, we're talking about we live in a small town. We're talking about a small community of people. And you know what? There's a need to sort of be careful and tread lightly and work with the community. And when that same group of people is a little bit frustrated by the circumstances that have brought them to somebody else's attention, those conversations get more and more and more challenging. And so there's a need to sort of embrace everybody who wants to do this work and at the same time be really, really delicate and careful about how that work is being done. So some of the things that have been, I feel like, very critical in at least helping us to continue to be able to do this work to the extent that it feels like we're gaining useful information that is useful from a sort of policy and programming perspective and continues to be useful to the community members and so that it's actually numbers that they want and that they're gaining information that's useful for them. So one is that there's and this is part of our national protocol, and then we have the opportunity to sort of structure it the way that it'll work here in Baltimore, is a pretty extensive formative research activity where, for starters, every time we go back out, it becomes really important to reappreciate what's going on with the community and with the locations where men may be found. And Baltimore is kind of interesting in that we're not a city that has bathhouses. We don't have, we're not the same sort of city that others may be facing. And what we have are a lot of bars, a lot of dance clubs. The racial dynamics are sort of shifting within them. We've got street locations. Some of them are sex venues. Some of them are just, places where people go to sort of meet each other. And it becomes really important to sort of stay on top of that and to appreciate how those dynamics are changing. And, as part of this conversation we had 2 weeks ago, we had a really, fired up conversation where you bring different people into the room who represent different parts of, what we like to refer to as the community, but it's really 75 different versions of a part of a community. And each one of those, people has a different sense of, oh, have you never thought about this place? Well, this place is actually really critical to my part of the community. And so making sure that the work that we're doing is actually successfully finding the locations that are useful to be working in, and then figuring out how to do that work in each of those areas. The process of community engagement and sort of continued community engagement, certainly there are a series of really wonderful community leaders that have been prominent in this work in Baltimore from the beginning and continue to. And then there's a whole lot of other voices that are not part of that, top 5 group of people. And we try to do our best to make sure that we're not just hearing from the top 5, but we're sort of broadening who we're talking with. And then asking them, very specifics about how we should do or what we should do, or, what should our staff look like and how should they act and what is important for as they're doing their work. And then somewhat as important, I would say, to all of the work that we do is the kind of work that we do on an ongoing basis. That's not part of these, every 3 years we go out and we do the MSM round, but it's everything that we do in between. And so we have been, and this is credit to Frank Savakis and the BSHR team prior to me, we've had a legacy of really trying to be engaged in the advocacy and the dissemination of the information locally and participating in media to the extent that the media has been interested, which has been a challenge. We do a lot of community presentations. We do palm cards of what our findings are back at the venues. We have a partnership with the state health department, which allows for our information, even if it doesn't directly get into the hands of community members, it's very directly informing policymakers and budgeting and decision making in that way. And we pretty actively participate in a few different local work groups that are sort of designed to help coordinate and facilitate information sharing related to MSM. And then just a lot of activities that sort of allow us to, many of our team members are, whatever you want to say the community is, are somehow or another personally connected to the community. And that's part of us, and that is, and that's very important to the work that we're doing. So one of the things that has come up for us over and over and over again is this sense of, it's great that you keep coming and you're doing this research, but what is it that you're doing besides the research part? And we had the opportunity somewhat recently to be funded to expand the part that has felt to be sort of programmatically most helpful, which is the testing component of our research activity. And so to be able to build on that testing aspect and try to learn from those activities. And so we're in the process of introducing this sort of HIV testing wing of our activity. And it's referred to as Project RE. And it's a partnership between our BSHR team and the University of Maryland Star Track, which is a group that has a really strong legacy of working particularly with young, particularly men of color who are a sexual minority here in Baltimore. And so it's a deliberate partnership between our two entities. And the idea for the name came from having the first series of conversations about what it is that is actually needed here in Baltimore. We have another HIV testing project. Well, what is it that's not working so well, or what is it that we feel like we're missing? And every time we talked about what was going on for the MSM community, all of these words came up, and the need to sort of reconnect and reach out and re-envision and do all of these things. And so Project RE was born with the idea that people can kind of create their own meaning for what it is that we're trying to do. This is the official word of, from the grant, what it is that we're trying to do. So we're trying to scale up HIV testing and linkage to HIV care among African American and Hispanic MSM and trans women here in Baltimore, primarily through our venue-based activities as well as a couples-based HIV testing activity. This is our transform version of what we're trying to do, and the idea is to sort of highlight this in a way that becomes a little bit more user-friendly. And what I want to do is highlight some language in here, which I feel like characterizes a little bit some of our style and our approach of what we're trying to do, as well as the kind of work that we try to do. So one is that it's a deliberate partnership, and partnership has been very much a part of our activities from the beginning. And so it's a partnership between our two entities, as well as the idea is to be as community grounded as possible. You'll note that the language has shifted from from MSM to trans women to a much broader definition that encompasses a variety of both behavior as well as gender identity, and persons of color becomes a sort of broader term as well. And then our work is in the community, trying to meet people where they are, doing something comprehensive, and deliberately trying to identify things that can be used by people who are trying to do this work currently and going forward. So there's a lot of activities that are involved that are trying to sort of make this useful. So I want to come to this point here, which is, so when we sit down then, when we're trying to do this work, what are the things that we're actually trying to learn, and what are the things that the community, whatever that really is, tells us about how to do the kind of work that we're trying to do, and what are things that are really important for them. And so one is starting out with the terminology. So, we've certainly heard MSM as a behavioral term. It's rarely an identity. And so what are the terms that are sort of meaning for any particular communication, as well as sort of more broadly. And then we talk about, people in this city have a lot to say about what has been effective for them and what hasn't been effective, and what are the things that make them feel excluded, and what are the things that make them feel really strongly included. And so to sort of share some of those kinds of things, when you come down to, and I could spend a lot of time explaining to you exactly what we've heard for each of these, but when you come down to what are some of the top 5 don't do's, those are, don't forget that we're people who have a lot of other things going on. Don't call us out. You can be subtle and you can still reach us. Don't take our, HIV is not fully the priority. Don't share my information if I didn't intend for it to be shared. This is a small, small, small town. If you mess up, we're gonna, it doesn't take long before that message to sort of to shape around. When we ask what's on your wish list for what are the things that you wish were going on, the conversation again goes way outside of HIV, and then they start talking about, well, I'd like a job, and I'd like a place to live, and they're incredibly well versed in the housing system in Baltimore, and who gets housing and who doesn't get housing. Is HIV actually a benefit for getting housing? And then we talk a lot about, is this that we're actually proposing something that feels useful to you? Does it feel like it's actually needed in the city? Yes. What about this that we're proposing? It seems like it's worthwhile. In what way how would you describe it as a worthwhile thing? Are there things that we can do differently that would make you be really excited about this? And who are the different people, and what sort of different entities within the community are people that could be really excited about it? And so we've learned a lot of different things, and I can share some of those. But this bottom part here, just sort of, we just kept hearing over and over and over again these examples of agencies or services or somebody where it was clear that they tried, they tried. And then there was a rumor that somebody's information got out, or then, some staff member was really, inappropriate in their language or in their attitude or in their behavior. there's a lot of conversation about what is appropriate or not appropriate in terms of sort of intimate relationships, and the sort of switch will flip very, very quickly. And so we had to stop and say, well, so on the possibility that we're not perfect and we mess up, how can we make this something that you trust enough that you're willing to tell us, actually you're messing up. We want you to succeed. What do we need to know before you walk away from us? And so, I want to sort of wrap this back into, I think what we were supposed to talk about, which was these ethical aspects. And I think that it all just comes down to things that, it's just respect. It's just sort of, working in the best interest of our community and not allowing for that sense that these are people who sort of lived lives over here and we don't appreciate, this is our community. Baltimore is a small town, and these are people whose lives matter in the city. And if we start from that place, then we can go actually, I think, really far. We just have to kind of do our best. So our list of thank yous for these projects just continues endlessly. So I'll just leave this up here. But so thanks for the opportunity.
No, I think that the challenges are similar. It's quite amazing how big town, small town, these minority communities are difficult to work with, whether they're large in size or small in size. I was thinking, in fact, we've been quite lucky in Cape Town because there was much more of a defined. It's a pink city. There was a more defined community base to work in, and when we started off, we used an ad agency whose definition of rural was Kailicha Township, which is about 10 miles away. That's about as rural as they could get their heads around, because Cape Town's quite insular. And so we soon found out, though, that the city bowl community, which revolved around venues and revolved around bars and clubs and bathhouses and beaches, was very different from the way we had to interact with guys 10 miles out. And it was certainly very, very different from anything we could do anywhere else in the country. So it's the challenge for us is actually getting community conversations going. Because unless you do it on a micro level within a very small community where people do know each other enough to gather and talk, it becomes really difficult to get this diverse grouping of people in a city to talk to each other. So I have respect for that part of it.
James, I have a comment and a question. The comment is that when I was in training in San Francisco, where there was a huge gay epidemic, I worked on IDUs, and the lack of respect and appreciation and warmth towards IDUs was stunning, even in San Francisco General Hospital's HIV clinic and ward. And everyone embraced the gay epidemic, and everyone was disdainful of the IDU epidemic. So it was a minority epidemic within a larger epidemic. Not that everything was wonderful for MSM in San Francisco, but it was a pretty supportive community, but for IDUs it was dreadful. And so it strikes me that you're in the situation where you have a minority epidemic, and it doesn't mean you're dealing with stigmatized behaviors all around, but at a larger level there's acceptance, but with the minority epidemic there's disdain, and everything you described. And my question is, in South Africa, you started off years ago with an MSM epidemic in Cape Town that was, not different from Rio or San Francisco or Sydney. And did that get any traction before the generalized epidemic, or was that also a small micro epidemic that was stigmatized?
So I think that your comment first, I think is true. Even within the small marginalised MSM community, and if you work in South Africa, there's a much smaller, even more marginalised drug using community. And in general, gay men are more entertaining than drug users, so they get away with more. But for health workers, but it's fascinating to see the stigmatization even within our own staff who are working in these clinics are finding it difficult now to deal with IDUs, coming in for needle exchange programs. So there are layers and layers and layers of stigma. The South African epidemic, I think, was quite interesting because it certainly did start in the early 80s with the first cases were in flight attendants who had been traveling, and it was a clade B, very similar epidemic to anywhere else in the Western world in gay men. And it was only really by the late 80s into the early 1990s that the generalized heterosexual epidemic started to take off. The government messaging and programming up to that point was first off, it didn't matter because they were gay men. It was in the apartheid days, so gay men were kind of just underneath black people in the views of the South African white regime at that point. And so there was very little done. But there was at least some recognition that there was a gay epidemic. What happened as the generalized heterosexual epidemic took off was that all of that disappeared. So state messaging and state prevention and care services completely ignored MSM from the 1990s. So it in fact was strange that it was there in the very early days, the Edwin Cameron kind of activist days, and then it disappeared, under the deluge of the heterosexual epidemic, and is only now starting to be recognized as something that needs to be paid attention to.
Great. Well, thank you so much, and really appreciate both of your